Hello, my name is Shirley Torho, and I'm a public health and education strategist with a background in using trauma-informed approaches and equity lenses to address the HIV needs of marginalized communities. Today, we'll address unpacking the intersections between HIV and opioid use in rural communities. This webinar is sponsored by the Center for Innovation and Engagement. Our agenda today consists of learning objectives, which we will review shortly. We'll also dive into the organization project overview, set the stage for today's webinar, review some promising practices for doing this work effectively in our given context, and finally, we'll look at some next steps for doing this work well. This webinar will serve as a technical assistance resource for the Ryan White HIV/AIDS program and the broader public health community. The specific objectives of this webinar are to identify intersections between the HIV epidemic and opioid crises in rural communities in the United States, to examine promising practices and how they can be leveraged to address HIV and opioid-related health disparities in a rural context, and finally, to assess organizational readiness and capacity to provide services at the cross-sections of HIV, opioid use, and other comorbidities. Before we proceed, there's a funding acknowledgement we'd like to put forth. This project is supported by the Health Resources and Services Administration, also known as HRSA, of the U.S. Department of Health and Human Services, HHS, under grant number U90 HA3 1882, Evidence-Informed Approaches to Improving Health Outcomes for People Living with HIV. The project is a part of an award totaling $4,899,570, with no percentage of funds financed with non-governmental sources. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the US government. For more information, please visit hrsa.gov. Additional acknowledgements include the fact that the presenter today, me, Shirley Torho, has no relevant financial or non-fiscal interest to disclose. Disclosure will be made when a product is discussed for an unapproved use. Further, commercial support was not received for this activity, and as we said previously, this presentation is supported by HRSA and HHS as part of an award. Next, we'll delve into the project overview. So who is NASTAD? NASTAD, which stands for the National Alliance for State and Territorial AIDS Directors, is a national nonprofit representing public health officials who administer HIV and viral hepatitis programs funded by state and federal governments. NASTAD works across all 50 US states, the District of Columbia, Puerto Rico, the US Virgin Islands, 7 local jurisdictions receiving direct funding from the Centers for Disease Control and Prevention, and the US Pacific Islands. How it does this work is that it interprets and influences policies, conducts trainings, offers technical assistance, and provides advocacy mobilization for US health departments. NASTAD's mission is to end the intersecting epidemics of HIV, viral hepatitis, and related conditions by strengthening domestic and global governmental public health through advocacy, capacity building, and social justice. NASTAD's vision is a world free of HIV and viral hepatitis. For this project, which is under the Center for Innovation and Engagement, is funded by HRSA, as we've said, and this special project has national significance under Part F with the goal to identify, catalog, disseminate, and support the replication of evidence-informed approaches and interventions to engage people living with HIV who are not receiving or who are at risk of not continuing to receive HIV healthcare. Partners for this project include NASTAD, Northwestern University Center for Prevention Implementation Methodology, and Howard Brown Health Center. This was a 3-year project, which was slated to end in August 2021, but has been extended through August 2022. The Center for Innovation and Engagement's goals are to identify, catalog, and disseminate innovative, evidence-informed models of HIV care. Key features of CIE resources include implementation guides, provider tools, videos, key information presented upfront, a cost calculator and how-to videos, a listserv, as well as webinars, technical assistance request systems, population-specific tip sheets, and so much more. For programs doing work in rural communities, the Positive Links intervention might be a great resource for you. Positive Links is a clinic-based mobile health intervention that promotes linkage to and engagement in HIV care in rural areas for people with HIV who are either new to care or at risk of falling out of care. This intervention uses a warm technology framework to enhance engagement with care setting and a broader virtual community of people with HIV. Next, we will delve into the webinar. Let's start by setting the stage. As some of you may know, in 2019, HHS issued the Ending the HIV Epidemic Plan, which has a goal of reducing new HIV infections in the United States by 75% within 5 years and by 90% within 10 years in 2030. Now, we know that we have wonderful advances in biomedical technology, as well as in prevention and also in treatment that allows us to do this. For instance, pre-exposure prophylaxis and evidence-based programs across the country. However, in order to achieve the goals of the Ending the HIV Epidemic Plan, we ought to really consider the dual epidemics of opioid use crises and the HIV epidemic in rural areas across the country. And so today's webinar will really delve into these intersecting epidemics and look at some promising practices for addressing these challenges as they emerge in rural communities across the United States. So a little bit of background. Over the last almost decade, the opioid overdoses that we've seen, as well as related deaths, have steadily increased, doubling in the years from 2013 to 2017. In addition, the current opioid epidemic can be associated with a new generation of users who live in rural areas that lack resources and infrastructure. When we think about medical care, for example, there's a lot of inaccess to quality care, and resources are distributed inequitably. In contrast to the heroin epidemic of the 1980s and 1990s, the current opioid crisis is whiter, more female, and in more rural and suburban communities where HIV is highly stigmatized. Moreover, changing demographics are largely due to use of prescription drugs such as OxyContin and the entrance of fentanyl into the drug supply chain. So the changing demographics and risk factors of this new opioid epidemic that we see tells us several things. First, studies have shown that young people ages 18 to 24 who use prescription opioids are more likely to use alternative routes of administration, such as injection, and to reuse non-sterile needles. We also see in research that white and Hispanic individuals have been found to have higher odds of using intravenous injection as a mode or route for medication abuse as compared to Blacks. With injection drug use linked to up to 72% of hospital admissions in HIV/AIDS wards across the country, especially in rural communities, we see that opioid injection poses considerable risk for contracting HIV and could lead to even higher mortality rates than what we're currently seeing. And so what does this mean for the populations that are mostly impacted in rural communities? Well, research suggests that people living in rural communities are more likely to inject both prescription and non-prescription opioids, which leads to poorer health outcomes. And poorer health outcomes means that rural individuals with HIV will be more likely to begin care with more advanced disease states. And they're also more likely to progress to acquired immunodeficiency syndrome or AIDS within 1 year of being diagnosed with HIV. In contrast, rural individuals with HIV are less likely to survive their diagnosis compared to people living in urban communities. This means that they have higher mortality rates overall. And so if we take a look at this map, we see that policy is a huge part of the conversation. So the map illustrates the 220 counties that are vulnerable to HIV or hepatitis C virus outbreaks across the country. And when we look at the blue dots, the blue shadings, these indicate the areas where the Centers for Disease Control considers vulnerable counties. The green shadings indicate where we find syringe exchange programs across the country. And the orange shadings indicate locations where both of these things are true. And so what the map really illustrates is if you look at the concentration of the blue shading in the southeast part of the United States, we see that there are actually very few syringe exchange programs in the communities that need it most. And so based on this map, only 18 of the 222 vulnerable counties have syringe exchange programs. So this is about 8%. And we see that certainly rural communities are less likely to have access to these syringe exchange programs. And in many instances, syringe exchange programs or syringe services programs are actually illegal in these rural communities. This map also demonstrates something that is very interesting. We see here in the blue shadings, the states where AIDS drug assistance programs have access to medication-assisted treatment for opioid addiction. Of the states that we see, only 26 have these types of programs. And we see that, again, the white shaded states tend to be states that have rural communities that are in desperate need of these opioid use and medication-assisted treatment programs, but don't have access to it. And so again, there is an inequitable distribution of drug assistance programs with medication-assisted treatment for opioids in these rural places, such as Georgia, in places like South Carolina, in North Carolina, and then in places like Louisiana as well. So now that we know what the issues are and what the challenges and gaps are in services, let's take a look at some of the promising practices. So we know that decades and decades of research tells us that harm reduction is a strategy that really works when it comes to not only HIV, but also opioid use. And so if harm reduction works, why haven't we taken more advantage of some of its strategies in rural communities? Well, let's start by thinking about just the basics, right? We know that in rural communities, transportation is certainly a barrier, and distance and access to healthcare is a barrier for many. So an article titled "Challenges Facing a Rural Opioid Epidemic, Treatment and Prevention of HIV and Hepatitis C" states that an estimated 80% of young people with HCV, hepatitis C, which usually is a marker for injection drug use, reside over 10 miles from syringe services programs, with larger coverage gaps in the South and in the Midwest. So again, this speaks to some of the challenges we see for rural communities. In general, syringe service programs have been proven to prevent HIV and hepatitis C infections in urban settings across the globe, but studies in rural settings are actually quite limited. We do, however, know that syringe services programs provide an opportunity for people who inject drugs to access testing, not only for HIV, but also for hepatitis and other sexually transmitted infections. Syringe service programs also enable access to prevention services and resources, including access to condoms and to naloxone kits for individuals who need it or who want it. SSPs also facilitate referrals to specialists. And so for individuals who are looking for medication-assisted treatment programs, for HIV or hepatitis C specialists, for even mental health services, and so on, syringe exchange programs or syringe services programs can be a great support for identifying and receiving referrals to these specialists. Additionally, syringe service programs ensure access to low dead space syringes for individuals who may be in need of those resources, and they support comprehensive evidence-based education, including how to disclose to sex and drug sharing partners. And so for all of these reasons, syringe service programs or syringe exchange program sites can be extremely beneficial for members of rural communities. Another promising practice is using the status neutral delivery model, which we've seen has worked very well for communities across the United States when it comes to HIV. And so when we look at this status neutral delivery model, we see that there's a continuum of care whereby we are able to address HIV prevention and HIV treatment and care needs across the spectrum. And so when someone comes in to access services, if they happen to be at high risk of contracting HIV, for example, there are a series of services and interventions that can be offered to ensure that their risks are mitigated or reduced. Similarly, if individuals come to a clinic to access services and they're currently living with HIV, there are a series of treatment and care services that they can access as well. And along the continuum, there are support services such as mental health and other social services that folks can access in order to meet their unique needs. And so this kind of a model is very intentional and targeted and ensures that we're meeting clients wherever they are along the spectrum of care. We can always leverage this kind of an approach when it comes to opioid use, particularly in rural communities. And so along the continuum of care, we see that on the prevention side of things, which is on the left side of the screen, we can, in addition to HIV prevention services, offer access to comprehensive prevention education related to opioid use. And we can also increase awareness of and access to prevention kits like naloxone. On the treatment side of things, we may work with people living with HIV or people who are currently injecting drugs to disclose to their drug sharing partners or to their sexual partners about their status, and also refer them out to medication-assisted treatment programs where necessary. And so you see this status neutral model can really be leveraged not only for HIV and even hepatitis C, but also for opioid use. And this can be quite an effective tool in rural areas where we're really pushing for a one-stop shop approach to services. And so speaking of one-stop shop models, we've seen that these one-stop shop models really combine multiple health and human service providers in a single location in order to deliver services to rural families. And there are lots of benefits, but some key benefits include increasing in communication and teamwork across care teams, which can also increase retention and success in care. And so when services are located in one place or in one space, rural families are able to come in on one day and access all of the services they need, not worry about transportation, other structural barriers that they have to overcome every time they leave their homes to try to access care. So really, this one-stop shop model enables families and individuals to be able to access all of the services they need at once and get all of their needs met in a way that is really streamlined and offers the unique services that they need. One-stop shop models also help to mitigate experiences of stigma. And so if there is collaboration between care teams, patients feel a little bit more comfortable and care teams get to learn a little bit more about their patients or about their clients in a way that reduces stigma, experiences of discrimination and prejudice. One-stop shop models also reduce mistrust between providers and patients because there is or a longer term relationship that is established. There's mutual trust and mutual accountability that is established, and that really supports trust building and therapeutic alliances between the provider and the patient. And then for one-stop shop models, even though costs can be prohibitive, health insurance and payment reforms are also quite definitely needed. We do see that folks are a little bit more interested in these types of models because it reduces the number of times they have to leave their homes and access services, particularly when they are living quite far from their providers or when they are located in rural communities. And so this diagram demonstrates different variations of this one-stop shop model. And so the first one that we see is a one-stop shop approach where services are located at different sites. They are at different locations, but the communication between the different sites is coordinated so that patients have an opportunity to interact with physicians who are communicating with each other and who are working together to optimize access to services and overall health outcomes. The second model demonstrates co-located services where perhaps services are located in one building. However, they are located across different departments or across different teams. And so that might be another model for less sophisticated one-stop shop approaches. The third model that we see is the partial integration, where we see that there's some overlap between care teams. So perhaps the teams are located in one building, perhaps they are working in one department, but not all the services are as integrated as they can be. And yet there is lots of communication and care teams have an opportunity to interact with each other to service the needs of the patient. Finally, we see the complete integration where all of the services are provided under the guidance of the same care team. And so this type of model is really ideal. However, depending on where you are in this, you may not be able to have that sort of an integrated model and must start, in one of these other three models. Another promising practice is the use of telemedicine and telepsychiatry to support the needs of rural communities accessing both HIV and hepatitis C care, as well as opioid use services. And so technology can look like a lot of different things, and there are a few examples that we've listed here. The first one being mobile technology, where folks are able to access resources online through websites or through mobile applications. And so essentially, they download an app and they're able to interact with their providers, with their counselors, with their mental health experts, with therapists, et cetera, and receive support that way. A lot of these apps and websites through telemedicine also have chat functionality. And so patients or clients are able to talk in real time with their providers and with their specialists in a convenient and confidential manner. There are also local networks that support virtual support groups, education sessions, interventions, and relationship building across communities and within communities. And so these practices are really useful. And in settings where telemedicine has been integrated, we've actually seen an increase in access to care and in interactions between providers and their patients. And so as you begin to think about some of these promising practices and how you might want to leverage them in your own context, we advise you to think about your own capacity and your own readiness to be able to do this kind of work. Service providers ought to ask themselves a series of questions in order to ensure that they are capable in dealing with the dual epidemics of the HIV epidemic as well as the opioid crisis in rural communities. And so here are a few questions to ask. The first one is, who are we serving? And so what are the specific demographics or characteristics of the individuals that you are serving, of the communities that you're providing support to, of the populations that come through your doors, et cetera, right? Who are these people? And are you actually able to support them? Are you able to meet them where they are? It's important to note here that a lot of research, particularly in rural communities, does not do a great job of segmenting out communities based on demographics. And so this is a very important question for organizations to ask, whether they work in government, in faith-based settings, or in community-based settings. Another question to ask is, what are our clients' specific needs? So what are the needs of the people coming through the doors? Is it that they need HIV specific services? Is it that they need opioid specific services? Is it a combination of the two? Or is it something entirely different, right? Do they need mental health support? Do they need access to other social support services? What are their unique needs? Next, you should ask, what comorbidities or co-infections should you be addressing in concert, right? If you're doing work around HIV or work in HCV, hepatitis, or supporting folks who perhaps have opioid use disorder, what other co-infections or what other comorbidities should you also be addressing? Is it STIs? Is it something else? And how can we really gather resources and optimize resources so that we're addressing multiple issues at once? Next, what structural or systemic issues should we also be addressing through our programs? Now, this question is very important because it really pushes us to think about, this social determinants of health approach and really addressing not only systemic, but also structural issues that arise. And so we've talked about barriers that we see in rural settings, such as an access to transportation, lack of access to specialists in HIV and other need areas. We also can think about issues such as access to quality nutrition, unemployment, mental health needs, et cetera, right? So what are some of the structural or systemic issues that you're seeing in your particular context, and how can you address them as you do work with these communities? Finally, how can you inform and or drive policy change? And so as you're doing work, how can you intervene on behalf of policy and really advocate on behalf of the communities that you're serving? And advocacy is a really important piece of it, because you really want to provide your clients and your patients with the tools to be agents of change in their own lives, right? You want to make sure that they know that they can use their voices and that they can advocate for themselves. And so in addition to really pushing and driving policy, how do you support your own clients and your patients with their own self-advocacy and advocating for their communities so that they're really the agents who are driving change in their communities in real time? And so as we think about next steps, it's really important that we think about how all of these things come together comprehensively. And so this diagram here on the right really pushes that agenda, where we're able to see how some of these structural issues intersect to produce the experiences that folks in rural areas or rural communities across the US face. But an effective approach to addressing HIV and opioid use in rural communities really requires organizations to be able to do lots of different things. The first one being that with the different promising practices and evidence-based approaches that we've seen, organizations really ought to be able to apply these successes to a local context, because there isn't a one-size-fits-all approach that works, right? The approach that works for one organization isn't going to work for the next one, right? If a faith-based organization, for example, is doing this work, the approaches that they're using may not work for a local clinic. It may not work for a governmental organization. And so what are the effective practices that you're leveraging, and how can you really apply them in a way that speaks to your own context so that you're really meeting the needs of the communities that you're serving? Next, we really advise you to acknowledge the impact of structural and systemic barriers. And so again, when we think about HIV and opioid use, when we think about hepatitis C and STIs, we really ought to be thinking about issues such as housing and access to primary care, access to health insurance, income stabilization. Do your clients have access to stable transportation? What do food assistance programs look like? In addition to opioids, are there perhaps other substance use challenges that you ought to consider? What are these structural and systemic issues, and how are they either compounding the issues or maybe mitigating the issues, right? We also want to ensure that clients have access to support services. And so once you identify these structural and systemic barriers, put in place systems to address these needs so that people have the support services they need. We also want to promote workforce development and expand access to professional development for all staff. And so in order to work with communities, staff need to be adequately trained to be able to handle the unique challenges of rural communities. And so if you're an organization that isn't hiring within rural communities, or you're bringing outsiders into work with you, what are the professional development and mentorship opportunities that you're putting in place to ensure that these staff or these employees have the resources and the tools and wherewithal to be able to support rural folks? Now, taking a step back, it's really important to ensure that your staff are culturally and linguistically proficient when it comes to the communities that they're serving. And so it's really imperative that you consider hiring folks who live in these rural contexts in which you're working. But if you're not able to do that, when you do bring people in to do the work, be sure that they have relationships with community members, that they're able to speak the language, that they understand the context and the unique challenges that rural communities face, and that they also have the comfort levels to be able to engage in not only a professional manner, but also in a personalized manner with the patients and the clients that are coming through your organization's doors. It's also important to engage community members at every phase of planning and at every stage of implementation. And so here, a lot of organizations will employ community advisory boards or community councils to be able to solicit the feedback that they need from community members. Unfortunately, some of this will happen at unique points in the planning or implementation phase of these projects. It's really imperative that community members be part of every step of the project, right? We want their voices to be included at every single stage from planning to implementation, and then create a feedback loop so that they're able to evaluate and assess the effectiveness of these programs that are being offered to them. And so here are a list of resources that we've included. These are all very wonderful resources that can help enlighten and elucidate some of the promising practices that we've talked about in the session. And finally, if you have any questions, please don't hesitate to reach out to me. My email address is shirley.torho@gmail.com. For specific questions about the project or to learn more about the Center for Innovation and Engagement, please don't hesitate to email healthequity@nastad.org. Thank you.